All right, as you know, this is a special session to learn about concussions, the influence of concussions on student sports and on student athletes, and I'm really happy that we're able to have this session. Dr. Strobert here has facilitated it, so it's really wonderful. I do want to make a note that we have delayed the start of our regular business meeting tonight until 6, so I'm hoping, normally we start at 5:30, so I'm hoping that questions and everything will be wrapped up by at least 10 minutes to 6, so that gives us a chance for you guys to go outside and visit or whatever you need to do, and then we can get on with our meeting to discuss things like budget and stuff like that. Anyway, Hank is going to introduce everybody.
Thank you. I'm Hank Dianger. I'm superintendent of the Ojai School District. I've been here now in my 7th year, finishing my 7th year. So welcome all of you, along with Linda. We have two other board members here, Jane Whipple and Kevin Rudd in the back. And the other two will be joining us at 5 or at least by 5:30. Al and I exchanged thoughts about this critical issue by email. He and I played high school and college football back in the days, not quite the leather helmets, but it was well before all the information about which we're going to learn today from our guest from UCLA ever would have been contemplated. We know some of the tragic results of just not having good information through the 70s and on later than that, particularly with NFL players. So, I just want to say a word about Al and then we'll move on. We wouldn't have some programs in this school district had it not been for Al's initiative and generosity, along with Betsy Wade, everybody knows Betsy Patterson, his wife. They have funded, both through their intellect and passion, and in some cases, money, programs like the Science Ingenuity program that we had for several years, which was really Al's brainchild. And so I thank you for your ongoing support. It's been wonderful. And today would not have occurred without him. I also want to introduce one other person who is representing his colleague also, Jim Halverson. Jim, a doctor in town, and he's on the sidelines for our home football games along with his colleague Carl Gross. And I've been with him an awful lot of minutes on the sidelines and watched him operate. Not technically, but operate in general with our program. So, Jim, thank you, and thank Carl, please, in his absence. And now I'd like to turn the program over to Al. Let's introduce our guest.
Being a man, a few words, I'm almost done. Anyway, I've been interested in this for a long time. Like you said, played football in high school and college, and then medical school, played rugby, which apparently is even worse, maybe. And one way you kind of wonder, gee, how could that career take a different arc somewhere along the way? But and also coach football here. In 2004, I recommended that we start doing preseason testing for our football players. Largely because I was motivated by a rotation in medical school in childhood neurology, and our professor was showing us, the total velocity curve of IQ distribution. He said, it doesn't really look like that. What it really looks like is sort of here, because there's nothing you can do to your brain that makes you smarter. And only, it's hard to make it better than you started with. And we'll see if that's changed in 35 years. But since, especially in the last 4 or 5 years, there's been a lot of acceleration of interest from stories in the newspaper, movies, how suits, a lot of blonde-happy people, some new research, and people coming online. And 3 years ago, the state of California made some specific rules about football, and CIF has made some specific rules about it. And they changed a little bit, and that's one of the things that we would like to do, is make sure that our teachers and our coaches and our administrators and our docs are sort of talking the same language, so when they say E2, they know what they're talking about. They're talking about the same thing, the language walking along the way there. And that's one of the main reasons we decided to learn this. And it turns out that we've had a great resource. I Chris Giza is a pediatric neurologist at UCLA that I knew from sharing patients from our cerebral palsy clinic there. And he has started a childhood brain injury clinic like 10 years ago, or more. And more recently, Steve Tisch, who's a NFL owner and a movie producer, gave a substantial hunk of money to Chris and his crew to make a real difference, to do research, to do outreach, and really make a difference in the database. So we are so lucky to have like best in the world guys right here, and we have our two people. Adam Darby, a neurologist who's now doing a fellowship here at Chris and these guys, who's also a sportsman, and which fits in very nicely. So he's one of us. He's a gentleman like that. And really, Cheryl is also a pediatric neurologist. Unfortunately, she went to the other medical school in Los Angeles. But she's been at UCLA for 7 years now. Okay, that's tennis. Okay, so that worked out. And she's going to tell us more about the brain program. So, Adam Darby, will you talk to us, please?
Thank you for coming, everybody. Great to see such a great group. I was talking to Al last week and just asking about what kind of people would be expecting here. So I heard there was going to be teachers, athletic directors, coaches, physicians, and so a very varied group. And that's great for something like this. Like I was saying, get everybody on sort of on the same page, all in the same room, and we'll have a question and answer session at the end here and try and answer as many questions as we can be. My role at UCLA, like I say, is so I'm a board certified neurologist, but I've chosen to sort of extend my training, and I'm actually doing 2 fellowships at the moment. One fellowship with Chris Giza and Dr. Che there, it's the brain sport program, so it's sports neurology, particularly looking at sports TBI. And then my other fellowship is in behavioral neurology, so a big emphasis on dementias and early onset cognitive changes. So at first, when people hear those two, they think, well, where's the meeting of those two specialties? But I think it's becoming clearer and clearer now that there is some overlap. With a lot of the news out there of these footballers and this CTE condition, which we're having many people come down to clinics and say, do I have this? Do I have this? And so I think getting education onto what that is and really what a concussion actually is. The number of people who come through our clinic and actually don't really know what a concussion is. I think just teaching them about that can be really, really helpful, very therapeutic, I think, for somebody to actually understand what a concussion is. So what I wanted to do today, my part here really was just for the last 7 or 8 months now, I've been working at really putting together sort of an up-to-date look at pediatric concussion. So looking at, there's a lot of stuff that's happened in the last few years, so trying to pull all that together. This presentation, some of the slides are going to be a bit busy, and that's because I guess I'm trying to make sure I've got things on there that are going to appeal to most of the people in the room here. There will be some pieces from studies and things like that, which I hope might spur others to go on and actually read further into those studies. Like I say, it's a very changing landscape at the moment. And then when I finish doing this, which should take maybe about half an hour or so, and I'm certainly willing to take questions as we go. But I think if you've got a lot of questions, we are going to have a question and answer session at the end, so maybe put some of those off towards the end to allow this to flow a little bit. After I finish, Dr. Che's going to come up and she's going to talk about the brain sport program, what we do at UCLA. Okay, and our clinic setup, etc. And then, like I say, we'll open up for questions. Okay, so just getting in, just starting with some facts. Just about concussion. So there's up to 3.8 million recreation and sport-related concussions occurring annually. When we're thinking about the pediatric population, there's about 3.1 million girls and 4.2 million boys participated in high school athletics in the 2009 to 2010 season. And you look at the ED visits there, so approximately 750,000 emergency room visits for pediatric concussion. And this was in a 2011 paper. But just looking at that, so we figured that number, 750,000 annual pediatric ED visits for concussion. And so many of you know about concussions don't go to the ED. So this is just the number that actually went to the ED. So that number is, if you're looking at that, it's probably a way underestimation of the numbers who are actually having these injuries. And some other findings that have come out, the injury rate seems to be higher in competition as opposed to practice. Highest in football, boys hockey, boys lacrosse, but as we'll get into in a little bit, when we look at gender for similar sports, females actually, so like for example, in girls lacrosse, there are actually a number of concussions per play. The number is actually bigger in girls lacrosse than it is in boys lacrosse. And as you see, that girls overall have a higher concussion rate as a group. And so a different approach is needed. So obviously we emphasize pediatric concussion compared to concussion in adults. And the reason we do that is because you're dealing with a totally different individual. We know that the life of a child is very different to that of an adult. Differing expectations for daily knowledge acquisition. They're frequently assessed, so we know they take a course, they've got an assessment coming up. Anybody coming to our clinic within a few weeks, they tell us they've got another test coming up. Oh, I'm going to miss this test, what am I going to do? So that's a huge part for them and a huge pressure often in trying to help people through this. And then just the different social dynamics and challenges that kids face. The role played by sports in kids' lives is very different as well to adults. I think whether you're playing it just as a means to be part of a group setup or you're aiming to go to the next level, there's certainly some different motivations at the pediatric level than there is at the adult level. And so just speaking to the fact that recommendations need to reflect this different approach. So the many signs and symptoms we can see in a concussion, and we often split them up into these different sets, so a cognitive subset, physical, sleep and emotional symptoms. Like I say, sometimes some of these things sort of travel together. There are some studies sort of looking at how they do. But certainly any of these can certainly be things we look for people coming through our clinic. I think the important thing to identify, particularly earlier on, is any sort of red flags. So some indications for acute evaluation are the same as in adults really. Things like seizures at onset, any abnormality on the neurological examination, repeated vomiting, worsening headaches. These would be indications obviously to get someone for the next step, so for an emergency evaluation if these were showing up in the acute setting. And obviously there's then indications to image as well, which ED physicians often use as to when to do a CT head scan. So the immediate assessment, so often we've got people, those charged with that immediate evaluation of those people on the sidelines, often using these symptom checklists. They've got these different, so there's the SCAT evaluations, which these systematic evaluations which involve balance assessments, they can involve cognitive assessments, maybe a brief neurological examination, a symptom checklist, and there's numerous different symptom checklists out there, and certainly I think that's something we could certainly provide. I can provide more information on if anybody here wants to know more about some of the symptom checklists. I can send you some resources on those. There are some that are it's a child version, I guess, which uses more child-friendly language, I think, which we find to be useful. And I think that's age 13 and under?
It's 5 to 12. 5
to 12, yes. Under 13s. And above 5. Yeah, okay. So that's the child version that we use and that's a more child-friendly language. But these are all things that are done in the immediate assessment phase. We use a lot of these in our clinic setting as well, which we'll get into in a little bit. But certainly used to make any return to play decisions. So these 4 key components often used. And there's the SCAT, which is now in its third version. It's testing all this. So I was looking at so this is for kids 13 years and older. The child scat is, like I say, 5 to 12-year-olds. This tests a Glasgow Coma Scale. It's assessing one's orientation. It does a symptom assessment. It's got the Maddox questions, which are questions like, you know, what was the score in the game, different things like that, asking sort of specific questions. And there's also some child's Maddox questions as well. The standardized assessment of concussion, which is a very brief cognitive screen, which looks at just some working memory and delayed recall aspects. That incorporates some orientation as well. And then a balance assessment, and some coordination testing, which is often just finger-nose evaluation, just looking for any subtle signs of abnormality in coordination. And the normative data is not really available for SCAT3 yet, but SCAT2 has certainly shown its worth for identifying concussion in the first 7 days. So there's no reason to think really that SCAT3 won't have sort of similar results. This is fairly new. And like I said, there's the child scat. So it's just slightly modified with more child-friendly language. So let's get into the pediatric vulnerabilities. What is it? What is it about? What's the difference there that makes kids maybe more vulnerable? Is that so? One thing that certainly is put out there from quite early is the relative size of their head. And we think about the size of a child's head. People out there saying the size of a child's head is up to maybe about 90% of an adult's by age 4 to 5 years of age. But then you think about the neck strength, and that is nowhere near that of an adult. So you've got that, you know, that real biomechanical difference, and sometimes we then go further and load that with some additional helmet weight as well. So certainly something there, and there's certainly been some data behind pushing neck strengthening in our pediatric populations to try and reduce this difference, at least a little bit. Degree of myelination, we know that this is incomplete, so that the myelination, which is if you like, the insulation of the connections in our nervous system, so in the brain there as well, that is incomplete through most of childhood and adolescence, and particularly the frontal lobes often go to the last to actually receive this complete myelination. And so studies sort of have shown that vulnerability in unmyelinated axons, at least in animal models. So there's potential there to think that these unmyelinated or less myelinated brains potentially could be more at risk. And once again, this is animal data, so we've got to take that for what it is. But that's a big difference, obviously, between, like I say, an adult and a child. And I think some of the estimates out there for when myelination in humans is sort of complete is sort of early 20s. And somewhat variable, but around early 20s. There's also some studies out there indicating that white matter disruption after TBI in these pediatric patients. And then just some other studies which show this FA, this fractional anisotropy, which essentially can show some disruption in the cell-to-cell connections, if you like. So that's been shown to be dysfunctional in children and adolescents after mild TBI as well. So there have been variable cutoffs, and these are often quite arbitrary, assigned to determine what symptoms are actually directly related to a concussion. So we know there's an event happened and there's some symptoms that show up. Which ones are actually directly related, and symptoms that are coming on days and days after, are they still part of the actual injury? And that's at the moment, like I say, there's sort of variable cutoffs. Something we're using down at our clinic at the moment now is one of the criteria we're sort of starting to look at is symptom onset within the first 24 hours being directly related to the injury itself. Now, once again, this is still yet to be rolled out as you know, what everybody's going to use. We found from a lot of our data that 24-hour mark is catching most of these things, and so things that are coming on later maybe are potentially indirectly related, not a direct result of the actual initial injury. But there are some studies that have shown that children may experience a bit of a delay in the onset of certain symptoms. So, and particularly things like the emotional symptoms and things which can be related and show up later. And in this, there was this study by Eisenberg in 2014, which was an emergency department study looking at kids who came through. And there were some of these symptoms showing up in the days following a concussion. So there is potential reason to think that some of these symptoms in children may show up a little bit later. And that certainly really is going to affect our decision making, and particularly return to play decisions. If you've got to think about, well, this person's not symptomatic, it's 12 hours now, we're not seeing anything, it's 24 hours, we're not seeing anything, do we have to pull that a little bit further before we definitively make that call? And then just the other thing of children, and particularly younger children, not always being able to be totally in tune with what they're feeling and being able to voice what they're feeling. So those add additional problems to this understanding. But obviously this is very, very important, this potential delay when making return to play decisions. This was a statement that came out of the International Conference in 2012, which was about 80 to 90% of sports-related concussions recover in 10 days. But this is all comers. This was a statement, a general statement that came out for all age groups. And there have been many studies here that have shown that there certainly is some variability to that, and some of the studies done in pediatrics have shown that children as adolescents may take, often will take a bit longer than that 10-day period. And a lot of time in our clinic now, we're sort of getting a little bit looser with that. That's, I think at first people were saying sort of 7 to 10, 7 to 14 days. We're certainly saying we're putting it out to the 3-week mark and things like that now, for appreciating that a child might, take to get back to where they were from a baseline standpoint. And you can see here, so some of the studies, it might be a bit harder to read back there, but so in a study by Collins in 2006, 25% of high school football players took up to 4 weeks to reach recovery criteria. Elementary, middle school children took up to a month to become symptom-free in this 2008 study by Lowell. When you're looking at comparing high school and college athletes, Iverson did a study in 2006. 50% of high school athletes recovered in those first 7 days. 90% of collegiate athletes recovered in that time. And so just certainly there are things out there suggesting a bit of an age difference and maybe a slight prolongation to recovery in the pediatric population. And then the other thing at the bottom was just neurocognitive recovery rates are similar in high school and college athletes. However, symptom reporting was actually higher in the high school athletes than the college athletes. So once again, maybe there's more symptoms there at baseline in that population as well, and that we'll get into the need and the reason for baseline testing here. So a concussion, really just a type of brain injury caused by a bump or blow or jolt to the head. It can also be a hit to the body. So you're just thinking of anything that's going to make that brain move inside the skull. So anything that's going to allow for the brain to move inside the skull. And Dr. Gies, I've heard him say this many times, to sit down with one of the children and ask, what do you think a concussion is? And we'll hear things like, it's when my brain gets bruised. It's when I got a little bleed in my brain. It's when my brain hits my skull and gets a bit damaged. So different things, and I think that's the big part of what we do is the education piece, and just trying to let them know what really a concussion is, because there are kids out there who are very, very scared by what's just happened and why am I not getting better and what does this mean. And so educating them as to what a concussion is really important. And his explanation is often, he talks about, thinking of a harder surface, and inside you've got like a jello mold, and if that was you were to shake that a little bit inside the harder surface, you might get a bit of stretching of the jello as it moves one way and then moves back the other way. And that stretching just stretches the communications between the cells. And that's a transient stretching. There's no actual breaking of those cells apart or anything like that, but there's some disruption in the way they talk to each other. And so just a transient disruption in that cell-to-cell communication. And that's often and how he explains it and breaks it down for the children. I think that can be sometimes very helpful. And then he comes back around with, so if allowed, the right environment and the right conditions, there's no reason to think that this won't just get, you won't be back to where you need to be, back to your baseline in the coming weeks. This is a completely recoverable, reversible injury. So why is this happening? Like I say, we talk about that stretching. We talk about this metabolic mismatch. So the energy production, so the energy that's being produced in those cells, and is being compromised. And the delivery of the things needed to produce the energy is not kept up with. So this is almost like a double whammy here. And we can't get the things into the cells that we need to get to in time, and the cells themselves are overwhelmed. And so that combo is really causing it, essentially builds up to cause this problem. And they think this is even longer in juvenile brain, mainly as a result of the hemodynamics. And they've shown in numerous studies that the blood flow and the hemodynamic component in juvenile brains is potentially even more effective than it is in adult brains. And you can see there from Chris's early work, evidence that even relatively asymptomatic patients may demonstrate depressed glucose metabolism on imaging. So certain types of imaging, we look at how the brain takes up the sugars, takes up glucose and uses it, and we look for areas that aren't using it as well. And even patients who weren't necessarily symptomatic clinically, you could see some abnormalities in the way their brain was using that. So obviously this becomes the challenge, identifying the duration of this period of vulnerability. How long is this going on? If this person seems to be overall just, they don't seem to be too bad now, how do we identify this period of metabolic vulnerability? And obviously that's why we come at this from all angles, and we have a multi-modality approach to sort of evaluation. And we use different methods of trying to make sure that all these different things we're testing, people are doing well at. So these are the supporting studies, like looking at the blood flow, particularly in the pediatric population. This study back in 2002 used the transcranial Dopplers, which looks at blood flow, and it showed the blood flow increase in the first day, and then it decreases for many days after. And these were in pediatric patients. So the blood flow to the brain was increased on that first day with an overload, and then you actually have a drop for the days following. A study in 2004 showed impaired autoregulation in 17% of mild TBI patients. So this was a pediatric group as well. So that you can see that regulation of the blood flow to the brain has been affected in a number of those patients. And in this more recent study, the decrease in normal cerebral blood flow following a concussion was shown to be significantly prolonged in an early adolescent population as compared to adults. So again, just making that sort of difference between the peds population and the adult population in that blood flow factor after a concussion. And then just one slide on this. I know there's some providers in the room here as well. I think very important just to bear in mind when you've got people coming through is obviously these structures, the pituitary and the hypothalamus are well in their brain. And there's certainly reason to believe that these things, just like anything else, could have some transient disruption. And some studies have shown that, and we often will, people will have certain symptoms when they come to our clinic, which will, it certainly, it could be explained by other things, but one thing that could be explaining it is some disruption to this hormonal axis. So we will, at times, send a hormonal screen on some of these patients. There was a study down there in 2007 by Nederland, which reported the high risk of hyperpituitarism in children hospitalized with TBI, and that was independent of severity. So yes, there was some moderate severe cases in this where there weren't just concussions, but they also included some milder injuries and concussion injuries. They had a higher risk of hypo, so low pituitary function. So some changes to their hormones. And things like that, obviously, we know those can affect things like knock-on effects on appetite, on sleep, or things like that. So those are things we need to pay attention to. So after a concussion, there's evidence to show that cognition and visual tracking can be impaired. Balance is worse. Reaction time slower. The brain biologically more vulnerable for a certain period there. And 3 to 6% higher risk for a second concussion. And this brings us to, so concussions happen. If we send somebody back too soon, they've got definitely an increased risk of getting a concussion. And we know that if they do get a concussion, the duration of their symptoms could certainly be more prolonged than it otherwise would be. So, a concussion on a concussion. A history of previous concussions, more likely to have future concussive injuries. Like I said, this has been shown in numerous studies. And the risk appears greatest in that first 10 days post-injury. Once again, for most, looking at that 10-day sort of recovery period, that vulnerability is there for about those first 10 days. We don't want to get somebody back into play, into harm's way before they've fully recovered. And this was an animal model by Miami Prins at UCLA and her team. This was in 2013. And they looked in their juvenile rat models. There was a closed head impact model. They found that when a second injury occurred within the period of impaired glucose metabolism, so while there was still something going on with the brain, it was still essentially being affected by the first concussion. If they had a second injury, there was a much greater severity of the hypometabolism and memory impairment seen. But if the repeat injury occurred after that full metabolic recovery, it just acted like a single concussion. Okay, so you had such a compounded effect when you hadn't recovered from the first one. Once again, speaking to how important it is to make sure that people have recovered from that first injury before getting them back into harm's way. So I'm not sure how many people have heard of this, and this is something that was really in the press 5 or 6 years ago, and I think we haven't heard as much about it of late, but certainly it was prominent enough back then to still be a concern at this point. This in a few cases where people were getting maybe suffered a first injury and maybe getting a second hit on top of that, there seemed to be this complete loss of cerebral auto-regulation and this vascular engorgement, so the blood getting into and that causing a big, essentially a swelling, an edema in the brain, and eventually pushing the brain from nowhere to go once inside the fixed cavity, and often pushing it down and causing death in a few individuals. The thought process or the underlying reasons behind it were sort of this catecholamine and glutamate surges that were behind this cerebral edema. But these were really only case reports. There was only a few real cases of this. And the other thing, they were described, I think the oldest person ever described this was 20, 21, was that a young person? So it was in a few pediatric cases, so no adults. And risk factors haven't been consistently supported. But because of how severe it was, it certainly is still on the radar of everybody who's dealing with concussions. So we talked about this repeat concussion, a concussion in that vulnerable period, but there's even data to support that a repeat concussion risk remains even after apparent recovery. So having a history of prior concussions increases one's chance of future concussions. Data coming out there in 2007, concussed high school athletes are 3 times more likely to suffer another concussion in the same season. And you could look at that and say, well, we'd like to see the breakdown of that. Were they all in those first few weeks after that first one? They weren't, but I think there were. The further you get out, the better your chance of not getting another one. I mean, that's accepted, but there still remains an increased risk. The Morale study in 2012 that between 11.5 and 32% of concussions among high school athletes are recurrent. A history of head injury is an independent risk factor for concussion, so taking other things out of the way, having had head trauma in the past, you have an increased risk of future concussion. And high school students with a history of 2 or more concussions continue to report more physical, cognitive, and sleep-related symptoms at baseline than students with a history of 1 or no concussions. And one would question whether having a lot of those symptoms at baseline, are some of those symptoms, do they increase your risk of further concussion? And we'll get into some of the other risk factors for concussion here. Sure, some people know about this, and this is the underreporting of concussions. I'm not sure who's out there, but as far as coaches and things, I know there's a lot of data supporting this being pretty prevalent, both high school populations, college populations, even at the professional levels. And we've got to ask, what is the reason behind that? There's some talk about it being a motivated behaviour on the part of the athlete themselves, a lack of understanding of the injury. So is it just the patient hasn't understood what it means to have a concussion, or what they're putting themselves back in harm's way by getting themselves back into the game situation? Is it just a difference in self-reporting data acquisition? Is there just a big difference there? Certainly studies, and like I said, I put it in red really because I think I don't need you to read all the details there, but really studies have certainly shown that a lack of awareness is, numerous studies have shown that, so a lack of awareness of what a concussion is, and how severe it could be to sustain a second concussion on top of the first, is repeatedly been shown in studies. And like at the bottom there, in this study, which showed that only 40% of concussion events and 13% of bell ringers, which is a term often used, recalled events were disclosed after possible concussion. So only 40% of them were disclosed in this cross-sectional study in high school male and female athletes. But what they did find was, when they looked and broke it down, those with increased knowledge about what a concussion was, those who had prior teaching, those who had a better understanding, actually had a higher reporting prevalence. So there are studies out there showing that people who are armed with the right information are doing the right thing. So post-injury predictors of longer recovery. What, after somebody's had a hit, is there something about what you see in the patient, some certain symptoms there that may tell you this person's going to take a longer time to actually get better, improve? And I think this can be very important, obviously, for ED physicians, for primary care physicians who are counseling their patients on, well, how long is it going to take to get better and things like that. I think it's important to know some of the things that maybe have been shown to potentially lead to a slightly longer recovery. And I'm talking about post-injury symptoms. I'm not talking about pre-existing symptoms. I'm talking about things after the injury itself. Prolonged headaches has been shown in numerous studies. Chronic fatigue and fogginess, those terms have been put out there in numerous studies as well. They've been sort of predictors of prolonged courses. And then amnesia as well. So if there was amnesia surrounding the injury, so some memory difficulties around the injury itself, that can certainly speak to a long recovery, and that's been shown in numerous studies. Although at the bottom there, I've written that there's a couple of studies there, one in 2011 and one in 2013, who didn't find an association between amnesia and protracted recovery. So I think this remains one of the modifying factors, if you like, as part of the American Academy of Neurology guidelines. Amnesia at the time of the event is still one of the modifying factors for a prolonged recovery. But like I said, we've got to keep pulling this data together to make sure we come up with the definitive recommendations. What did come out of the Meehan study was a total post-concussive symptom score. So that score that they fill in, higher scores on that did seem to be associated with prolonged recovery. And so, speaking to the reason why we do that, there just seems to be a lot of merit to actually getting that score filled in. Now, this is something for a lot of people I think helpful for teachers and other people out there to know what things that a person maybe had going into a concussion might put them at risk for put them at risk for increased chance of concussion, and two, in prolonged recovery. And so this looks at some of those things, and some of the pre-morbid risk factors we often think about. Anxiety and depression, so pre-morbid psychiatric diagnoses and conditions. Attention deficits and some learning difficulties. Those have been repeatedly shown as well to impact sort of the concussion course. And a history of headache and migraine as well. Migraines has certainly been shown as one thing that could prolong the course itself. This slide here really is just talking about the anxiety and depression. And you see there from 2012 study, we see that it's quite a wide range there. But symptoms of anxiety, depression, and irritability occurred up to 46% of high school and college athletes. So certainly a number of high school and college athletes with pre-morbid psychiatric symptoms. There's no actual prospective evidence to support that pre-existence of mood disorders predisposes an athlete to concussion. There's no study out there definitively saying that. But it's not difficult to see how such symptoms could complicate one's recovery. Some of the symptoms we see in a regular concussion, a lot of them are affective symptoms. Things, they can have some irritability, they can have some changes to the way they're feeling, some emotional changes and things. So certainly somebody with a pre-existing mood condition, it's, like I say, not difficult to see how symptoms like that could complicate the recovery process. We've seen high school and college athletes with severe depression report more concussion symptoms than athletes with minimal and moderate depression scores. So once again, greater symptom reporting overall. And then mild to moderate TBI patients had persisting cognitive dysfunction that was linked to comorbid major depression. So once again, this speaks to another reason as to why we need to get our baseline evaluations on people. We need to establish these baseline conditions. Is the fact that we're seeing these comorbid major depression in these concussion patients, is this telling us that maybe this patient had something pre-existing? Is this really just a function of the concussion itself, or did they actually have something pre-existing? And the only way we'd ever know that is to have evaluated the patient prior to getting the injury. So once again, really speaking to why we try to get baseline testing on as many people as possible. And it says here, teens with a history of concussions are more than three times as likely to suffer from depression. Now, once again, we know that concussion can have a lot of symptoms in that sort of cognitive emotional category. But once again, is that speaking to some of these patients have a pre-existing dementia? Pre-existing depression that was never actually picked up. And once again, baseline testing. Up to 5% of the US pediatric population experiences migraine. The mean age of onset in boys is about 7 years, girls is about 11 years, and we know the prevalence increases throughout adolescence and into early adulthood. There's a female predominance, and that often occurs until middle age. And it has been shown that there's an association between a concussion and pre-existing migraine hasn't been reported at this point. So linking, does having a pre-existing migraine increase your chances of having concussion? That hasn't definitively been shown. But what has been shown that having pre-existing migraine has been associated with prolonged recovery period. And we can see at the bottom there that post-traumatic headache correlates strongly with other migraine symptoms among youth with concussion, regardless of pre-morbid headaches, and speaks to this other thing we talked about, which is that post-traumatic migraine being, is that just a total separate entity? Can it happen in people who don't even have a history of migraine? And that's what we're trying to pull apart at the moment. But we do know that migraine can prolong and complicate the recovery process. And then finally, attention deficit. So there are numerous studies looking at this. You can see some of the stats there in children 5 to 17 in the US, about 9% prevalence of ADHD. The male greater than female ratio has been well established with ADHD. What we do know is that children with ADHD are more likely to be injured than children without ADHD. And studies do support an increased chance of severe head trauma. There's no definitive study out there at the moment saying linking ADHD and saying a history of ADHD definitively increases your chance of having a concussion. but it's not hard to see when you look at children with ADHD are more likely to be injured than children without ADHD, shown time and time again. Studies to support do support that increased chance of severe head injuries in children with ADHD. So I think we often do take from that announcement the fact that that history does increase your chances. And we talk about things like kids like that, lower attention levels, more prone to participate in fast-paced, unpredictable sports, and that's once again being reproduced study after study after study. Greater risk-taking behaviours can be seen as well. And then so on the other side of that, children who have a history of concussion are more likely to develop ADHD, and that was found in just a recent 2014 study. Once again, a lot of those patients didn't have baseline testing, so we don't know if they had pre-existing, that was never picked up. And there's patients with ADHD statistically significantly more disabled after mild TBI than control patients without ADHD. And just getting into the gender differences. Okay, I'm going to wrap up here. The gender differences, you can just see, looking at boys lacrosse here versus girls lacrosse, certainly. So for similar sports, you see, whereas boys and girls soccer, you see in girls soccer higher rate than in boys soccer. And why do these gender differences exist? So female athletes experience higher rates of symptoms at baseline, that's been shown in numerous studies, and throughout recovery, and particularly for certain symptoms. And so, like I say, there's potentially just a higher baseline there. But then we get back into that weaker neck, the relatively weaker neck in a female compared to a male. And then numerous studies really pointing to the role of the sex hormones. Women who suffer a concussion may heal slower if the injury occurs in the 2-week premenstrual period. That was shown in a fairly recent study. And so a question of a progesterone influence on some of the symptom set. We know that rates of depression are greater among females in adolescence. I told you about migraine being more prevalent in females than males as well. So once again, although it's just a function of an underlying hormonal influence. And then post-concussive syndrome, just get into this real quick. These are the same risk factors of those for sort of prolonged recovery. This is, there's different terms for this, and it's sort of up in the air as what constitutes post-concussive syndrome. For a while there, they were saying that it had to be a 3-month duration of symptoms. There's some of the newer guidelines now don't even put a duration on there. It's just symptoms that came on at the time and have persisted through. But once again, we've got to come up with, and now our goal is to come up with some time in the near future an agreed upon criteria for this. Once again, same risk factors that we said for prolonged recovery. So if you have a lot of those, like the premorbid migraine, the anxiety, depression going into a concussion, if we have the ADHD and the learning disability, those kind of things can certainly be risk factors for post-concussive syndrome. Increasing age has actually been suggested to be a risk factor, and that once again is all coming, so that goes all the way into adulthood. So that's more getting into the older adult population. In adults, older adults seem to have high chance of PCS. Sports-related concussions as a group are actually less likely to progress. We certainly do see it, but less likely than other groups. And one of the big groups that will often progress to post-concussive syndrome is people who are involved in litigation. There's a few studies questioning that at this point, but for a long time that was something out there as a risk factor for progression to post-concussive syndrome. And the only thing I wanted to put down here, and certainly good for ED physicians and people who are seeing people at the beginning of their symptoms, is there anything about somebody in your clinic or in the ED, when you look at what symptoms they're reporting, is there anything about what they're reporting which would help guide your discussion of the course ahead and their chance of progressing to post-concussive syndrome? Numerous risk factors put forward here. They've now ended up, this study, which was pretty much brand new, hot off the press, came out with this scoring system that's going to be available for ED physicians, I think, at some point to maybe try and use. to actually come up with proposed levels of risk for developing this based on what they were presenting to the emergency room with. So you can see numerous symptoms there. Female sex, age of 13 years or older, migraine history, previous concussion with symptoms lasting longer than 1 week, a headache, sensitivity to noise, fatigue, answering questions slowly, and errors on our balance assessment. So, like I say, this could be really helpful for physicians in the future, something like this. And then just getting into the importance of this neuropsychological assessment. Big deal, like I say, for not only to establish a baseline reference point, but can also pick up those pre-existing conditions. A good formal neuropsychological evaluation can really help if you're seeing a patient after they've had a concussion. There's no real recommendations of when to conduct something like this, but we're incorporating more and more into our patient visits. And actually with brain support now we have neuropsychologists in clinic with us who can at least do a briefer bedside analysis, which is very helpful. And it can be a big part of trying to get students back into back to some kind of normalcy, having the neuropsychologist input. And like these can be very sensitive to subtle cognitive impairments that we wouldn't necessarily pick up on cognitive examinations. So these are the, once again, this is important to get these baseline testing. I know I've said it so many times here, but let's get them before a concussion happens. It's so good to know the athlete, how the athlete did, was functioning, any problems they had before they had their concussion. But emphasizing here, there's not a single test to diagnose or treat concussions. We use so many things together. And the neuropsychological evaluation or baseline evaluation is just part of that. Ton of things here, just see that I've underlined there. Only 4 states at this point actually require baseline testing, but many states are starting to incorporate it. And just as why we need to do it as well, because on those evaluations that I told you at the beginning, that SCAT evaluation, those brief concussion screens, they were finding big differences with age and with sex. They also found in this third point down, in this 2012 study, that 9th graders had much lower scores than upperclassmen on the self-reported and self-reported concussion. Prior concussion history really affected the total scores. Anything else I want to get on that? And then the 2 other things about baseline testing, which I really want to include here, is when to do it. So in collegiate athletes, it has been shown that extending the interval out to 2 years didn't really see much change in that period. But no such studies has been done in pre-college athletes. So at the moment, the recommendation still is to continue every year for baseline testing, and I think that's reasonable at this point, given how much we see kids change over that time. And the last point on here, really important to make. This study in 2014 evaluated and found the prevalence of invalid baseline results increases when testing is conducted in a large group and actually also in a non-clinical setting. I think the point there is the large group, and we've seen this when we've got to make sure as best we can we try to control these environments and make them as standardized as possible. Very hard to do, but that's a big factor going forward, is trying to look at the environment where allowing these evaluations to take place. And then the 2 biggies, as far as physical and cognitive rest. I know I'm going over here. So cognitive rest and physical rest were 2 things that were really put out there and have been for the last how many years. And we still get many referrals to us, and we'll often hear is, well, the physician told me that I had to just shut down. I've had a concussion. You need to go home and shut down for until you start feeling better. And we're finding we're seeing these patients 2 and 3 weeks later, and they weren't getting better. If anything, they're actually worse than they were at the time of the initial injury. And what we were finding was you had these active, engaged, social individuals who athletics was a big part of their life, were being removed from all of these activities and just totally removed from, once again, the social interactions, their athletic pursuits, all the beneficial activities in their lives. And we're actually finding an increase in certain symptoms. People are more depressed, and some of the other symptoms were more manifest. And so there's been a big sort of shift in that at the moment, looking at how we approach these athletes. And yes, there's a bit of data there supporting an initial period of cognitive and physical rest. That's in the span of a day or so of just being out of things, just get away from things, unplug, and just be out the fold. And then trying to get people back into their regular activity, as far as gradually trying to reintegrate into a school environment, with accommodations, with whatever needs they have, but just trying to make sure we maintain some kind of normalcy to allow these people to function. And the big thing we go by is obviously return to learn before return to play. But we're often okay with people doing at least mild to moderate aerobic activity alongside their return to learn. Okay, so completely, you can imagine somebody who athletics has been a huge part of their life. It's been, they've done it every single day, and then you just take it away from them for, there's 3 weeks there and I'm not doing anything. I mean, that's a huge deal. So having some kind of athletic activity going on, nothing that'll put you in harm's way, but just we'll talk about, and we'll show you the graded return to play, but some mild aerobic exercise, like light swimming or a gentle jog or something like that, is helpful alongside returning somebody to a school environment. And there's numerous studies. In the interest of time, I better just keep going ahead, but certainly showing what I've just said, the importance of getting back into things. And you can see just the top one there. This activity restriction cascade was described by DeFazio in 2015. This cascading process, so removing an individual from validating life activities and combining this with physical deconditioning contribute to the development of persistence of postconcussive symptoms in some youth. So a real big deal. So ultimately the goal is to keep disruptions to the student's life to a minimum and to return the recovering student to school as soon as possible. Obviously consideration for informal targeted accommodations while doing that. And then controlled, non-contact, mild to moderate physical activity does have a place in the recovery process. But once again, we talk to people about really paying attention to symptoms and symptom exacerbation, and we have that graded return to play. And nobody returns to any actual contact activity until cleared. And so this is the product. What about return to activity? Rest, the 1 to 2 days, limited, no work. Then begin recovery. Start some cognitive effort of your partial return to school. We talk about whether it's a reduction in class time, whether it's a reduction in homework. Both of those. There's numerous things we put in place. No standardized testing in that initial period. This gradual activity increase in cognitive effort, return to school, monitor symptoms, may start non-contact risk exercise, return to normalcy, normal school, and then you can continue return to play progression for your physical activity. And this is the return to play progression. Symptom limited rest. Once again, after those first few days, once somebody's getting back into their academic environment, can begin with some light aerobic exercise. Could progress to some sports-specific aerobic and movement and running. And then non-contact training drills. Once again, still not involving any chance of head contact. And then eventually, once cleared, we can start getting back into the full contact practices. And we have different durations for progressing through these, and it often depends on how long somebody has been symptomatic for. Prolonged courses, we may stretch this 48 hours out a lot further before we progress through that. Once again, I think what I'm speaking to is the fact that this is very, very individualized, and we really do pay attention in this to the individual symptoms and the individual themselves. Okay, without further ado, I'd like to hand over to Dr. Che just to talk about brain sport for a few minutes, and then we'll open it up for questions. Everybody okay?
Okay, I'll just try to go quickly through these slides, just to tell you a little bit about who we are. So brain sport was developed, as Dr. Jarvie said and Dr. Storberg said, about 10 years ago. Dr. Giba started brain sport and looking at pediatric traumatic brain injury and concussion. And so what we do is we focus on sports concussion in the youth athlete. So looking at treatment and raising public awareness, so through education, developing programs for prevention. I said outreach already. We do also research both in the clinical arena and the basic science arena. And then the treatment program, much of what Dr. Darby has described to you already today. I don't think the video is going to play, but Dr. Giza is very proud of the fact that the donation, the very generous donation that we received from Mr. Steve Tisch, who's also the owner of the Giants, was announced at President Obama's summit on youth concussion. We received $10 million to use for our research and education programs, and so we've been developing that over the last couple of years. So most of you in the room are involved in sports in some way. You were a former athlete, as both Dr. Darby and I are continuing to be athletes. I've also been a high school coach for over 15 years. And so we all know what the benefits of sports are, right? So Dr. Darby touched on this. Physical fitness, really important for our kids. Obesity is an epidemic in this country. Long-term health benefits. So we know that this benefits us in the long term in terms of our cardiovascular risk factors, as well as, I said obesity already, and then diabetes. There are cognitive benefits, and there are a lot of studies looking at how exercise in the short term and long term increase different chemicals in your brain, as well as prevent neurodegeneration in the future. And then also this big benefit of teamwork and leadership, which kids can't learn in any other way really other than out in sports. So again, clinical care, education, and research are our big programs. So clinical care, I'll show you the people, that'll be easier. So Dr. Giza, Sue Udovin, our nurse practitioner, they've been doing this for many, many years. I joined the team a few years ago. I was a fellow prior to Dr. Darby. As Dr. Darby mentioned, we also have neuropsychologists that are affiliated with our team. We have, on the left side of your screen, some basic scientists in there, as well as our programmatic team. Constance, who's right in the middle, she's responsible for a lot of our outreach that we do with the communities, and we go to many school districts as well as many schools, both at the high school, middle school, elementary school level, and talk to them about concussions, athletes, parents, coaches, administration. We're affiliated also with sports medicine, and then of course this last year we gained 2 fellows. We're lucky to have Dr. Darby as our half fellow, who's also doing neurobehavior, and then Dr. Polster is our neuropsychology fellow. Why is youth concussion and focusing on youth important? Well, while most of the research has been being done in professional sports, more than 3 million people, or more than 3 million kids play football alone at the junior high and grade school level. And if you include soccer and ice hockey, that over doubles the number of kids that are participating in sports. And those are just soccer, football, and hockey. So we talked about what to do already if a concussion is suspected a little bit. So, coaches on the sideline, if you recognize a concussion, that kid needs to come out. As Dr. Stroberg mentioned earlier, there was a law passed about 3 years ago, and kids have to come out. They cannot return same day. They have to be evaluated by a licensed healthcare provider. And actually last year or the year before, they just signed into law that they can't return to contact within 7 days. So now the rule is in California, they have to go through that return to play protocol that Dr. Darby outlined for you, and it should take them 7 days to get back. That includes they have to visit their provider twice in that time to get cleared before they can go. So the student athlete then is protected from additional concussion risk, which Dr. Darby so greatly outlined for you guys is very important in that first 10 days. Then they're evaluated by an athletic trainer. This is what our ideal scenario looks like, using some kind of multimodal protocol. There's not a single test that can diagnose a concussion, so it's really important to use a multitude of tests to help with the diagnosis. That's compared theoretically to a baseline performance if one is obtained, and then they are referred either to their family physician or our team for treatment. and provided, this is important, individualized return to activity plan as they recover. So not just their return to play, but more importantly, their return to school. It's very important that they get an individualized plan. So we work really hard with deans, athletic trainers, coaches, teachers, and I talk to trainers probably on a daily basis outlining how we think that the kids should return back. And so then they can return to play safely. All things that are important to improving youth sports safety, so good technique, so we could probably avoid a lot of injuries, and there have been studies that have shown that just heads-up football alone, that new tackling technique has decreased the number of concussions in youth football. Avoiding unnecessary contact, so I know in the Ivy League, they've gone to no contact practice during the week, so the only contact they see is in the games on the weekends. Using protective equipment properly, so making sure that your kids are wearing their helmets if they have helmets, wearing their helmets and they're fully inflated with the protective padding inside and that their helmets fit, enforcing rules consistently, and identifying and managing concussions properly. Dr. Darby already outlined the multimodal approach that we utilize in our clinic and for baseline testing. Sorry, I'm going quickly so that you guys have time to answer questions or ask questions as well. We feel like preseason baselines provide a point of comparison for each athlete, as although for each testing modality that we use there are validated kind of normal scores for certain age groups and certain genders, it's not as good as having a comparison to the preseason baseline. So we provide education for different members of the community. This is just outlining our baseline, usually what we do. So we go to the site, we perform baseline testing. Parents have the option to opt out of our study, but it's basically just collecting numbers on our end. We share our results with the school athletic staff, whoever is the appropriate person, either athletic trainers or medical staff, and then they get cleared for play or referred for further evaluation if a concussion occurs. Just keep going. So our clinical care is a community-based model. As I mentioned, I do speak to a lot of trainers. I speak to teachers and deans on a regular basis. Of course, when the patients are in the in the clinic, then we speak to the families as well as the patients and make sure that everybody understands the plan as we go forward. We have a lot of affiliations with different groups. I myself am part of the World Boxing Council Female Division, so I advise them on their medical practices, and USA Swimming. Dr. Giza is a consultant for a variety of things as well. And we have a study going with the NCAA currently that's funded by the NCAA and the Department of Defense. At UCLA, for the varsity athletes, the varsity football players have helmet sensors. These are to be utilized only in research purposes right now. We do get questions a lot from outside organizations, can we use this to diagnose concussion, but no standard numbers have been developed yet. So we've done some of the research, but it looks like it's pretty individualized again. So we can't come up with a number or a threshold where we know a concussion has occurred. Constance has put together a digital platform, so we're using iPad technology right now. So we have an app, or not an app, sorry, we go to our website, we enter all of the information on the iPad at the schools. That information is HIPAA protected, so it's confidential, and then all of that gets put into our database, and then we can share the information with schools if they need baseline numbers. Last slide. Okay. Sorry, I hope you guys got most of what I was saying. If not, we have an email as well as a website you guys can go to if you have more questions that we aren't able to answer for you today here. Currently we have 3 locations, all in West LA, which I know is quite far for you guys, but we've seen patients definitely from this area. I've had patients come down from as far as San Luis Obispo. They just leave really early in the morning or stay overnight. Okay. I think this next one is questions. Yeah.
I have a question.
Of course.
The baseline testing is obviously really important. Have you all developed a standardized testing that coaches can do?
So typically what coaches or athletic trainers might do is the SCAT, which is what we feel is like the minimum, the sports concussion assessment tool. So there's the brief symptom checklist as well as the brief cognitive test. There's some balance in there and coordination. It takes about, you could probably get it done in about 5 to 7 minutes a kid. In addition, some programs, or unfortunately actually, some programs are only using computerized cognitive testing, and so the most popular is IMPACT. That's just because it's been the best marketed. It's not any better than any of the other tests. But what we're seeing is that, so one of the things that Dr. Darby mentioned was that if you do it in a large group, it's not as valid. So a lot of schools are giving that in like an auditorium classroom setting, and then those baselines are not very valid. There's also a pretty easy way to game the system, and we see a lot of times that athletes can just kind of not take their first test or their baseline test seriously, so that if they do get injured, it's not hard to meet that baseline standard. So we recommend kind of a combination of those things. So we'll do the SCAT as well as the computerized cognitive testing, and then we add a few other things. We do a brief neurologic exam as well as a reaction time test. Yep.
I have a question. Earlier you mentioned something about having a second concussion after the first within the same year that you're actually playing. Is that after the 7 to 30 days of rest, and then they come back, that percentage is still as high, or?
Yeah, that was just one of the studies that I'd shown, and a few others have certainly shown that. So two things we're talking about here. In that initial period, that vulnerable period, if you're more at risk of having a repeat concussion.
So within
that initial period, that first, whether it's 7 to 10 days, whether in child it's like 3 weeks, within that first, there's an increased chance because, as we showed, things like reaction times are off and things like that are affected by concussion. So it's not difficult to see how one might be at increased chance of getting another concussion in that time period. But it has been shown beyond that as well. That's people who've had, and that one study was really talking about a history of 2 or more concussions in their life. There is an increased likelihood of a repeat concussion. There just seems to be a higher chance of getting another concussion if you have had prior concussions.
So I just want to add a little bit to what Dr. Darby said. So it's true that the risk is higher in the beginning, but the risk ends up being probably lifelong, and we don't know why that is. So there could be some reasons, right, that are not controllable. Like there might be a genetic predisposition, but there might be things like you have bad technique playing, so you put yourself at risk every time because you haven't learned the right technique. So that might be a thing. Another thing might be you might be more impulsive on the field, right? So if you're more impulsive, you might put yourself at risk a little bit more than the average player. So that might be why that risk is higher. We don't know.
I've noticed more concussions with schools with artificial turf fields than natural grass fields. As an example, last year we had, out of the 72 kids, there was 27 kids that ended up with concussions throughout the entire year. I've been coaching up here at Nordhoff for 10, almost, this will be my 10th year this year, but we just, you might have 1 or 2 during the season, strains, that kind of thing, but I personally had never seen that many concussions on a field, and it was the first time I'd ever coached at a natural or an artificial turf type field. So
has there been like a similar mechanism in some of them? Has there been like a?
It was literally the tackle to falling to the ground. It wasn't anything head on. It was just your head got whipped, or you just the head was hitting the ground. You could see the head bounce. The immediate pain, the timeout to get them off the field. We did have sensors. We had a pre-protocol and post-protocol, so we were able to evaluate them in and out. But it just seemed like it was just really interesting to me to see that many more concussions than I'd ever seen. So I'm wondering if part of the graph that you have with soccer and with lacrosse it incorporates that.
So that's a much older study, so I think that it probably doesn't incorporate now there's a much higher use of artificial turf. I've heard that actually about all injuries with artificial turf, not just concussion.
Okay. Thank you.
Question?
Yes.
A common question. Tim Williamson, I'm a pediatrician and ER doctor as well. But there was a careful avoidance of using, talking about loss of consciousness in this presentation for good reason. But does loss of consciousness and duration of loss of consciousness increase the complications of concussion?
No, so it might change what you do, right? So if you see a prolonged loss of consciousness for a provider, you might get a CT, you might be more likely to get a CT, but it doesn't look like loss of consciousness plays a role in how recovery goes over time. And you're right, I don't think we necessarily neglected to say it or intentionally didn't say anything about it, but really only 10 to 20% of mild traumatic brain injuries or concussions involves loss of consciousness.
Hi. School nurse, both high school and elementary school. I mean, I think the biggest question that I have, especially since in the last 3 years, this has been brought to our attention and we have every student sign that concussion form, is a lot of pressure on when do you send for further medical care. I mean, it's just that as a first kind of responder, everybody's looking like, is she going to do the right thing? And I'm looking at the parameters of the baseline and then the immediate symptoms, but it's almost like, send them. You guys.
Well, I think
It's really hard.
The law now is, I think they have to be evaluated.
Okay.
So even, like, if you suspect it at all, they have to be evaluated before they can return to play. Now, that's in the case of somebody who is an athlete and wants to go back to the field, but obviously concussions occur in all sorts of settings, not just on the athletic field. And in that case, I would say if you have any discomfort, then I don't think there's anything wrong with sending them to their regular provider, who also might know them better. I'm not sure, you probably know your kids really well too, but they might have a different perspective on the kids' health.
Yeah, and just to say that, so obviously there's a bit of a difference between an ED referral, obviously, and then the provider, which can, if you're suspecting that, then you can make that appointment with the provider in the next day or so with the appropriate education. But I think the ED things which we talked about there, the time to send to the ED, obviously any concern for any seizure activity, like a prolonged loss of consciousness, certainly something that needs to be just at least evaluated, like a prolonged or recurrent loss of consciousness, so coming to and going, actually going unconscious again. I think the other thing really is when you have anything on I don't know how much of a neurological examination you do, evaluation. I mean, maybe there's just some brief things that you can do as part of that, because certainly an abnormal neurological screen is a reason to refer for an emergency department as well, so someone's balance and things and coordination is off.
And then worsening headache, vomiting, those are things, or changing mental status. So if they go in and out, like you said, of consciousness, but if their mental status is changing, then that would be reasonable as well, I think. Yes?
Is there any firm criteria risk for emergency room doctors to proceed to get a CT scan?
Yes, actually, there are the PCARN rules, the Pediatric Emergency Care Network put together rules for greater than 2 and less than 2 years of age, and they include like a severe mechanism of injury, worsening headache, vomiting. I'm trying to think what else is on there. Those are like the big ones.
The loss of consciousness.
The loss of consciousness, right. And then for the ones less than 2, it's like the parents feel like the kid is not themselves. That's another one. So it's important to get the parents' perspective as well.
So it's just not the fact that a child is brought to the ER for a possible concussion. That's not the only criteria.
Right. And even and the on those PCARN rules, they even say that, like, for a lot of those things, if the provider is comfortable and feels like they can just observe for a period of time and then release the kid without getting a CT, then that's also an option as well. And maybe the better option, because obviously with CT you're exposing a child to radiation risk. Right now, Dr. Giza and I are on a committee putting together guidelines for the CDC for pediatric TBI, and that's one of the questions, is when to recommend a CT based on the studies that have been done, and certainly observation is perfectly reasonable in some cases, most cases, in fact.
Does a second concussion within the same season change the duration of return to contact?
No, it doesn't. But a second concussion will often have prolonged or symptoms that last longer than the first. Not always, but sometimes. And so you might be stuck with a longer return anyway.
But it's not an automatic?
No, not an automatic.
Is that would that, and to stick my neck out a little more, with a third? It would seem to me, I mean, we start to hear numbers about repeat concussions, and maybe they shouldn't play, 3 concussions in a football season, maybe they shouldn't play the rest of that football season, for example.
Right, so that's kind of dependent on the individual, but the reasons we might retire a child from contact sport or recommend retirement, because obviously that has to be a big discussion with the family and the patient, but would be concussions getting closer and closer together in time. So certainly 3 in a season would seem like they're getting closer and closer together, especially when you're talking about a high school season being maybe 3 months with a postseason short run. So that's one thing. If there's mild cognitive impairment, that's demonstrated on neuropsych testing. So for kids that we might think about that in, we do get neuropsych testing. Any changes on imaging, so we get MRI for those kids to see if there are any things that we need to be worried about on the MRI. And then threshold, so if there's a lower threshold for getting a concussion, so let's say I've had kids tell me they get out of the car, bump their head on the top of the car as they're getting out, and that gives them concussive symptoms, then we also say that that's another reason to retire from contact.
We need to get ready for our board meeting. I guess you had a question, maybe our last question.
The doctor almost answered it. My question was, in your opinion, how many is too many?
So again, individualized, there's not a certain number for any kid that we, I wouldn't give you 5 or 4 as a particular number, but I'm sorry.
How about 8?
Well, so there's some things that you can't control for, right? So you might say to that kid, okay, please don't play football or lacrosse or hockey, but you can't say to that kid, okay, then don't, do track and field, right? Because the risk is lower. You might aim them towards a lower risk sport, but again, there's some things that you can't control for.
Let's give our presenters a huge round of applause.